Hi, my name's Tammy Gorzella. I'm the substance misuse nurse for the Acute Trust. I've been in post now for over 12 months, and the aim of this session today is to look at the hospital guidelines for managing opioid users on the ward.
I'm Dr. Karen Williams. I'm a consultant psychiatrist with the mental health liaison team and also a consultant in addiction psychiatry. And I've been working with the liaison team for just over 11 years. So section 1, drug liaison role and other services. So Tammy, can you say a little bit about the drug liaison role and how you got involved?
Yeah, so the role was advertised in January of 2023, and it came as a result of what they found with people with substance misuse issues were not receiving good treatment in hospital. Yeah. They were not getting prescribed the correct medication, which led to a lot of them either an increase in violence and aggression incidents or leaving hospital having not completed the treatment. And a lot of this came down to them not getting the correct prescribed treatment. Yeah. So they weren't getting prescribed at all. We're still experiencing about 5 people a month who don't get the treatment for methadone or buprenorphine prescribed.
So people are just sort of ignoring their substance
misuse problem. I think some
completely.
of it is confidence. I think people, I know that in other hospitals, methadone can only be prescribed by people who are at a certain level, like registrar and above. Okay. So I think maybe some junior doctors or junior members of staff don't have the confidence. And I think because it's such a specialised area, a lot of people have maybe never prescribed it before. Yeah. And we're dealing with such large doses that it can feel a little bit overwhelming.
Yeah, absolutely. It's just really important to get that prescribing safe, isn't it? But you just can't ignore the problem, because otherwise, I mean, we had loads of issues, haven't they? I mean, probably before you came, but we've had people who, you know, overdosed and died in hospital, and similarly people who needed to stay in hospital didn't stay because they weren't getting the substance misuse treatment, and they left, and then, you know, then probably suffered consequences as a result of that.
And it's not just about the prescribed treatment. Obviously, physical side effects make up one part of it, but it's also about cravings and about managing those psychological, effects or withdrawals that people have.
Yeah, absolutely. Yeah. So do you want to say a bit more about how you do your role, a bit, sort of the practicalities and that sort of thing?
So I work on a Monday to Friday basis, with Wednesday being my only non-working day. And I do an assessment and prescribing service as well as a liaison role. So in terms of assessment, I will see all patients who are admitted to the hospital who have been highlighted as using opiates and are in prescribed treatment. I will ensure that they prescribe the correct amount, and where necessarily, after I've completed an assessment, I will also increase the prescribed treatment if needed. The other liaison role is what we know is that people will present to hospital with a non-fatal overdose prior to a fatal overdose. So part of the role is also liaising with the key workers in the community, which is currently a company called VIA, and letting the workers know that they've presented to our hospital that could be because of an overdose, so that they can offer timely interventions in the community.
Yeah. And you work a bit alongside the pain team as well?
Yeah, so I work closely a lot with the pain team, with alcohol liaison. Polysubstance misuse is a massive complication, so ensuring that we're all working together to do that, not only liaison, but working for the best of the patients. Yeah. And obviously, I also work with the DART team, which is the drug and alcohol in reach team, and they offer. We will discuss them later, but they offer psychological support, and they offer a bridging service between inpatients and community services for ongoing psychological support.
Because I think some people get really confused about them, don't they? But they're not clinicians. I mean, they're really, good drug and alcohol workers, but they can't do any prescribing or advise you about prescribing or anything like that.
Yeah, no, they don't do any of the prescribing. They can confirm doses if somebody's in treatment, and they're really good at doing motivational interviewing, look at why people use drugs, and doing craving management, relapse prevention plans, which is just as vital as prescribed treatment.
Absolutely, yeah. And I suppose it might be helpful for people to know a bit about the services that are available in Gloucestershire for substance misuse.
Yep, so Gloucester's a bit different from other services in that this comes solely from an organisation called VIA. They are the sole provider of prescribed drug treatment services in the county, and that's for people in prescribed treatments such as opioid substitution therapy as well as alcohol detoxification. And they offer group support, relapse prevention, needle exchange through pharmacies and services like that. They also work with people who misuse benzodiazepines and also prescribed medications such as codeine and other medication.
Yeah. And alcohol, of course, as
and
well.
Alcohol.
But that's right, they're unlike other services in the country. They don't. GPs don't really do much
in
prescribing.
Gloucester GP, I think we don't have currently any GPs, so there's no shared care in Gloucestershire. It's just all through VIA. So one of the other lead stakeholders is the Nelson Trust. They have dry houses that people can go to for rehabilitation, group work, and housing support.
But they don't do any of the prescribing.
They don't do any of the prescribing.
No. Okay. So section 2 then is we're going to talk about hospital presentation for people using opiates and why these patients with these sort of problems might come into hospital.
So some people come into hospital as a result of an overdose. This can be accidental and it can be deliberate. Not all overdoses are accidental. And there's a significant number of people who misuse substances who also have coexisting mental health problems. The other thing could be as a result of a complication of injecting. So maybe bacterial endocarditis, abscesses, pseudoaneurysms, DVTs. And what we're seeing is the heroin population is actually getting older. So we're more likely to see patients with comorbidities. So respiratory problems like COPD and a substance misuse problem.
I mean, I think it's really true to say that a lot of patients with substance misuse problems just don't go to the GP.
They don't access healthcare.
And I think if you've been using opiates for a long time, it really affects your hormones. So that really impacts on bone health. So you get osteoporosis. A lot of them have got terrible dental problems and really then it's just they're just avoiding going to the dentist and then ending up with really multiple problems in the mouth. And a lot haven't really looking after themselves anyway. Maybe have things like diabetes, don't they? And you end up with not looking after the diabetes properly. And yes, I think if you're chronically using opiates, your respiratory system's affected. You just don't have such a good cough reflex, so you probably are more likely to get chest infections, that sort of thing, aren't you? And then we've just got a lot, I suppose, that have been involved in incidents, accidents, various things, and then they've got chronic pain. And that, of course, makes things difficult because actually the opiates that they're taking for the heroin addiction isn't helping the pain anyway, so they've got a background of chronic pain. And then I think it's also interesting because I think when I was a bit younger, the patients with heroin problems weren't using alcohol, but there's now an awful lot of coexisting alcohol misuse. So some people end up coming into hospital, don't they, with both needing an alcohol detox as well as maybe managing their opiates as well.
And then maybe with a community-acquired pneumonia, which just, again, further complicates the situation.
Absolutely. I mean, and there's lots that have also got like comorbid other substance misuse, so benzodiazepines as well, and we're going to talk a bit more about those, but ketamine and cocaine as well as the heroin. So there are a few patients in the county that are HIV positive. Obviously, the needle exchanges were really good at reducing people contracting HIV in the 90s, but there are a few folk around, and we work quite closely with the HIV team if we need to, and they're based at Hope House, and their extension is 0300 421 6500. I suppose just a really important thing, actually, just thinking about medication, because we came across this recently. There was sometimes the HIV medications aren't recorded on DUI, so that actually it's really important that you try and find out if somebody is HIV positive, what medication they're taking. And then there's a really good website looking at which will help you with interactions with HIV medication, which we can share with you as well. And then I suppose lastly, just thinking also about the there are some substance misuse midwives in the hospital, and they're seeing a lot of patients with drug and alcohol problems who are pregnant. And just, I suppose, a special point really, isn't it, that if you're opiate dependent and you're pregnant, then actually that's really quite important that they get that sorted out. You can't just send somebody away from A&E without any help. They're about the one population where you'd really want them to get some fairly quick treatment.
Yeah, of course.
Yeah.
Section 3, this is looking at the hospital opiate guidelines, and we're just about to tell you where these can be found and what support is within them.
So really helpful guidelines, hopefully, and they are found, probably the easiest way to find them is on the vulnerabilities page on the intranet, and they are called, they're A0062 opiate users on the ward management guidelines, so you can sort of Google those or whatever the equivalent is on the intranet. But I think probably, the easiest way is through the vulnerabilities page,
So on screen now, you will see the Trust intranet page. If you type in vulnerabilities to the search bar, the Trust vulnerabilities page will come up, and if you scroll down further down, not only will you find lots of information about dolls, alcohol misuse, but also the drugs information can be found there. So the Trust guidelines are mainly aimed at the doctors who prescribe, the pharmacists and nurses on the ward. But I think it's good for most people who have patient contact to be aware of them for how to effectively manage opioid users.
Yeah.
So Karen, I know you designed the guidelines. What were the guidelines designed for?
So the idea really is to help patients who've got opiate dependence and pain issues. So they were developed by myself and various members of the pain team anaesthetic department, and they have been updated on a number of occasions. So the idea is you help patients manage the withdrawals first off, and then it helps you then work on pain issues. And, the idea being that you help the patient stay in hospital long enough so they can get the treatment they need. Hopefully it'll stop patients prematurely discharging themselves from hospital, and also reduce the risks of people doing, using on the premises, or maybe getting their mates to bring some drugs in for them and using in the loos or whatever.
I think the guidelines are really important, because I know that this, I've recently had an experience where a patient said that she would like to be on 80 milligrams, and unfortunately that was just prescribed rather than following the guidelines. So she was increased from 30 milligrams to 80 overnight,
which is really
dangerous. Yes.
Yeah, and exactly. So it's to stop that random prescribing, either ignoring them or just randomly prescribing a really big dose, both of which can be pretty dangerous, really. Yeah.
So how do you use the guidelines?
So so basically, what you want to try and do is to get the patients established onto a safe dose, and so you get the withdrawal symptoms managed okay. And then look at the analgesic needs on top of that. So if you can get the opiates down, then you can get the analgesic needs sorted out. And then you're just using like a normal pain ladder. So you usually start off with things like paracetamol, non-steroidals, if that's appropriate, mixing the two together if necessary. But then I suppose the one important factor is you then avoid using the weak opiates, because there's probably not much point, and actually theoretically might make people go into withdrawal if you give them weak opiates while they're having their methadone at the same time. And then I think it's also just thinking about the other pain management that might be helpful. So using getting the pain team involved. Sometimes gabapentinoids are helpful, but those can be difficult if people are using illicitly as well. And also just thinking about other pain management, really.
I found when I started that the floor sheet was the really easiest to use initially whilst I got used to the guidelines, because it shows you in a clear linear way about assessing people, the questions to ask, about taking a history and what are the good questions to start with, looking at guiding you through looking at what questions, the assessment, withdrawal symptoms. Is a urine sample indicated? I know we're going to discuss the complications of getting a urine sample for confirmation of opiate testing, obviously. And it also acts as a prompt to remind to check about things like alcohol use, thinking about bloodborne viruses and about nutrition. We know about the role nutrition has in wound care. And it also goes through highlighting safeguarding issues and how you refer to different services, such as myself or the DOIC team.
Yeah. No, I think you're right. I think that's what, if I ever do any teaching, I do say start at the flow chart right at the top, and then that's really helpful. I think it's, for some reason, when you open up the guidelines, that's probably the most straightforward place to go. And then the idea is, I think you can then go, are they really, or do we think they're stable on the methadone, having taken a good history and got some collateral information about it? Or are they not in treatment at all? Because some people are just come and they're not in treatment. Not everyone's in treatment, or they're actually in treatment, but they're still using drugs on top. And then I suppose there's the other people who are on buprenorphine, who are a different category. And the idea is it can guide you through those like 3 different scenarios, really.
Which I think if you've not got much experience of working with opioid users, you can't go wrong if you use the guidelines, because it's really clearly set out.
Yeah. I hope so, yeah. Yeah. So, Tammy, do you want to say a bit more about taking history and how to assess and examine patients with substance use?
Yeah, so, I mean, my usual approach is to introduce myself. It's to make sure I'm very clear that I'm not there to penalise people because of the drug use, and what we want to do is make sure they're on the right treatment to make them comfortable and feel safe in hospital. So I will always take a really clear and detailed history of both illicit drug use as well as prescribed treatment, how much have they been using, when did they last use, what route, because that can have a big impact on the complications. I look at how long they've been using for and what signs of dependence they have, what withdrawal symptoms they might experience. Obviously, you've got things like injection sites, leg ulcers that you might need to assess. And obviously also looking at the presentation while they're in front of you in terms of sedation levels, whether they're drowsy, responsive, which might indicate recent use. And obviously, the gold standard not only in the hospital but also across the country, is that you do get a urine drug screen.
Yeah.
However, it's worth highlighting that we don't have access to near-patient testing, which is the immediate testing at the patient's bedside. You have to actually collect a sample and send that off to the hospital laboratory, which then takes 7 to 10 working days to return. So that's got... you can't rely on the, unfortunately, at the minute, the urine testing as a way to verify drug use.
But I suppose it can be helpful, possibly as a baseline, can't it?
Yeah.
But yeah, if you've got somebody just in and out in 2 or 3 days, the results will have come back. Won't have come back till the patient's left.
Gone.
Yeah. Okay. Yeah, I mean, opiate withdrawal symptoms are quite interesting, aren't they? I suppose quite a lot of people probably haven't seen them. But the classic thing is they're described as like cold turkey, aren't they? So the patients, they've got the hair standing on end, and they're shivery, and they're a bit like a flu-like symptoms. And what a lot of it seems to be caused by is noradrenaline or a noradrenergic storm. So they've got gut cramps and the other bit, I suppose, is just they feel terrible, really. And they feel miserable and they're fed up. And I suppose the most important thing to say about opiate withdrawal is, apart from the pregnant women, it's not dangerous, but it is unpleasant. And I suppose if it's unpleasant and it makes people feel cross and angry, so people in opiate withdrawal are feeling irritable anyway. So actually, if you can get the opiate withdrawals under control,
if you can get them in prescribed treatment, it reduces that need for maybe violence and aggression call-outs or behaviour contracts, which we don't really want, and most of our patients don't want that either.
Yeah, absolutely. I suppose the other thing is sometimes we could think about also what people look like when they're presenting, having taken opiates. And, a lot of patients, if they're very stable, you won't really notice very much at all. I mean, you'll maybe notice the pinpoint pupils, but that's probably about it. But actually, if somebody's acutely using and they're not particularly stable, they are often nodding on off to sleep, gouging out, which is sort of just like nodding off, isn't it, essentially, and very sedated. And obviously, then it can be very risky because you get a low respiratory rate and shallow breathing. And that's how people die from heroin overdose, isn't it?
Yeah, because the respiratory rate, which is obviously, like we said, is complicated if somebody's also been using alcohol, which further can depress the respiratory system, and things like benzodiazepines also have the same effect.
Yeah, yeah. It can be difficult though, can't it? And then I think sometimes people are very sleepy as well if they've been using loads of cocaine, and then they maybe come into hospital and not using the cocaine. So it can be difficult. So I think sometimes you just need to get you involved, really, don't you? Sometimes to help with those symptoms.
You know, the earliest recognition and getting specialist teams involved, whether that's myself, pain team.
Yeah.
I have had experience of people who've come in, who've been stable on the methadone for many years, we're talking 10 years, who've come in with community-acquired pneumonia, have been very unwell, but they've put it to the methadone and they've reduced that. And actually it's probably as a result of other complicating factors, not because of the methadone, because the tolerance is such that we wouldn't normally see that. So it's usually, it's about having that inquiring mind and digging a bit deeper.
Yeah, absolutely, yeah. So what's the best way, do you reckon, to try and find out about what people are taking if they're on prescribed medication? Tammy, what's your top tips?
So the main one is obviously either get in touch with myself and I will confirm the dose. The second one is to contact the organisation VIA that we've already referenced, and we'll put the number up at the end of the presentation.
Yeah, absolutely.
And contact them, and they will confirm whether they're in prescribed treatment. So on the ward pharmacy, will confirm doses with the community pharmacy, and they use summary care record. Unfortunately, you don't have access to methadone prescriptions on Dewey, joining up your information, so it's through summary care records, so the pharmacy will do that. You can also, especially at weekends, liaise with the community pharmacy directly about whether they've taken the dose and what that dose is. And I think what we know is, again, because of Gloucester, we don't have many GPs who prescribe, if any, at the moment. So what we know is if you follow the guidelines and you've got somebody with an unconfirmed methadone dose, you know, it clearly says of what you can do in that situation, because I think it's far better to give somebody the 20 to 30 milligrams that you're able to while you research some of this information, rather than leaving them, you know, with nothing. In terms of the one thing to highlight is we have approximately at the minute 30 patients who are on an injection called Buvidal. That's injectable buprenorphine, and it lasts for about a month. And all of these patients should have an alert when they enter the hospital. So alert will come up highlighting that that's the medication they're on, because that raises concerns about pain relief options and things like that, because it's not reversible. Yeah, because it's a partial agonist, isn't it? And you can't just willy-nilly pile in lots of medication, maybe. Yeah, so it's just really important, isn't it? You get that history from VIA and the pharmacy. VIA, of course, aren't open over the weekend or out of hours, are they? But the VIA will give you, or VIA or VIA will give you the information. And I suppose I was just thinking, because the other bit is, if you go to the pharmacy, they can actually go tell you whether the patient's turned up that day or when they last picked up. Because we had, you know, sometimes patients might have not picked up for 2 or 3 days, and then if they haven't done that, then their tolerance will have gone right down, or they must have been using other stuff, and then you probably have to go back to trying to treat them as if they're not stable on a prescription, don't you, really? I suppose the other bit some people might be worried about, we did say there's quite a lot of patients who are using opiates and alcohol. What do you do then, Tammy, if you come across somebody who's using both alcohol and drugs? If somebody's after the assessment, I will liaise with the alcohol liaison team to see if they're known, and obviously make a referral to that team if they're not yet known about starting on the CEWA. And I think whilst we have to treat things jointly, I think it's also really important to look at some of the withdrawal symptoms could be crossover. And it's difficult to tell the difference sometimes between withdrawal symptoms, people being anxious as well. A lot of withdrawal symptoms mimic anxiety, such as the sweating, the shaking and the GI disturbances. And I think we've got to be careful, because if somebody is on a C where they're prescribed a lot of diazepines, benzodiazepines, so they will have a risk of respiratory depression. So it's really important that those early referrals to the specialist services get done as soon as possible. To try and sort of give them the best possible chance. In terms of from prescribing, what investigations need to happen in the hospital? Well, I mean, I think you obviously want to just do your routine tests anyway, but I think also maybe thinking about bloodborne virus testing, and there is a
bloodborne virus test nurse who's in the trust. I think, I'm not sure she's full-time, but I think she's available. I guess the other bit is just sometimes you have to think a bit about capacity. So you can't obviously force people to have treatment for their substance misuse problem, but if actually somebody is delirious and lacking capacity and they need to have some treatment, you can't, just because people are saying they want to leave, you can't necessarily take that at face value without thinking about have they got capacity to make an unwise decision. And then I guess the other bits are thinking about other risks. So, have they got, I don't know, dependent children? Are they in like domestic violence situations? Have they got mental health risk assessment? Because I do think a lot, you've said before about overdoses, and I think sometimes it's just automatically assumed that any opiate overdose is an accident, and sometimes I think it isn't. It's absolutely a serious intent. And then I suppose just from a sort of more clinical point of view is just also we do, and it mentions it quite a bit on the guidelines, doesn't it, about just thinking about ECGs, QTC prolongation if you've got people on high dose opiates and then maybe particularly in combination with other drugs. Okay. And actually the guidelines have got quite a lot of detail in that if people want some more information about that. Yeah. So just thinking about, I suppose, so we're thinking about our group of patients who we think are probably fairly stable on methadone, as far as we can tell. Yeah. Presenting well, and that sort of thing. How do you usually approach that then? How do you go about prescribing for those patients, Tammy?
I will usually confirm the dose with buyer if the pharmacy haven't already completed that. I'll go and see the patient, check they're stable on that dose. How long have they been on it? Have they been using on top? Have they recently had discussions about reducing, about increasing, or do they feel, fine on the dose that they're on? And as a new prescriber, I'm really careful when I prescribe that I only give the 1 milligram per mil. I have, while I've been here, become aware that there's injectable methadone. There's also different doses. So it's really important that you prescribe the correct, medication. They also need writing up for PRN naloxone. If a patient does suddenly become unresponsive, it's really vital that that's for the staff on the ward.
That's right, because even if you've got the history, you might not have got it 100% right, or somebody might introduce some of the drugs that will make the methadone dose sort of rise because of inhibiting the metabolism and all that sort of thing. So that's right, you've got to just go for naloxone. And I suppose it's important to say it's not you that's got to stop the prescribing, is it? I think it's probably the junior doctors that can do it. And we don't have a rule that certain levels of
No, that's open for everybody. And like I say, the guidelines are really clear that if it's an unconfirmed dose, 20 to 30 milligrams, will make them, that patient stable. And obviously just referrals to the pain team, myself as needed.
For those, for the people that you're worried about. Okay.
In terms of, looking at prescribing for patients who are not stable on the methadone dose or are admitting to using illicit drugs, what do you do in that situation?
So again, you're looking at that flow chart again, you're looking at the following the guidelines, and it says patients new to methadone or current prescription unknown. And as we've said, really, you start people on 20 or 30 mils of methadone, oral methadone daily. And then you use the clinical opiate withdrawal scale to sort of monitor the withdrawal symptoms. So a little bit like the CEWA, you can then have them on a safe lowish dose, 20 to 30 mils. So even if you made a mistake and they're not opiate using, that's unlikely to cause anybody great harm. And then you can then monitor for withdrawal symptoms on top of that. Obviously, you write up the naloxone, because again, that's probably even more important for these folk because we're not entirely sure what they're doing. And then the COWS scale does give you a sort of indication of what you should do and how often you should review everyone. It's not on the EPR though, and it's all paper-based, isn't it? And people will have to just do it quite carefully.
So the COWS are the clinical opioid withdrawal scale, and they're actually within the guidelines. You can print a copy off, and it's also called the RD1.
On the guidelines,
And it shows you how to monitor opiate withdrawals, about how often you should score, and it's got a scoring system for different symptoms such as anxiety, sweating, shaking, restlessness, things like that. I mean, the basic rule of thumb is the 20 to 30 milligram starting dose with somebody who's experiencing, I'd say, mild to moderate withdrawal symptoms. They can have 5 milligram every 4 hours. After the previous dose, and if they've got moderate to severe withdrawal symptoms, they can have up to 10 milligrams after the previous dose. I think it's being really clear about whether you're prescribing 5 or 10 milligrams. I think ambiguity doesn't always help in some situations. And then what I tend to do is on day 2 or 3, or as soon as I can get to that patient, I will look at how much they've used and consolidate it into one dose. What we need to be aware of is usually on day 3, watching out for opioid toxicity. That's when it could be at its peak. And obviously we're aware that some people, they won't achieve steady state until approximately day 5. I think these are always difficult in if they've got different kidney function, renal function, but usually the baseline is day 5.
Absolutely. So sometimes it is just really important, isn't it, just say to the patients, we might not quite... But might not quite get your the dose needed until sort of day 5, and so bear with us really, and we're doing our best. And the worst thing, of course, is just somebody then trying to use extra on top, and then you just never quite get themselves very stable, really.
So what about prescribing for people who are stable on Espranor?
So Espranor is a drug they're using in the county, which is the buprenorphine type that they're using in the county. There are other things like Subutex. I suppose sometimes people come from other areas, don't they, into the trust. So that might be worthwhile thinking about. And again, there's just a really clear bit in the guidelines about using section 3, and it just tells you a bit about buprenorphine. So this is the oral dispersible type, which can either be put on top of the tongue or under the tongue if it's the buprenorphine. And again, you just do the same sort of thing where you're just checking the dose, the prescribing, and whether dispensing and whether they've taken it or not. I suppose a lot of people who are on the sublingual or a dispersible buprenorphine are often a lot more stable, actually, generally speaking, aren't they? And then I think if you've checked as far as you can that people are on that dose, just give them the dose. But I suppose there is a bit of a problem, isn't it, if they then need opiate analgesia? So don't they want to say a bit more about that?
So the usual, again, I think we've already said this, but it is in the opioid guidelines. But I think the main rule of thumb is you can do something like splitting the dose. So anything 8 milligrams or above, you could split it into 4 milligram in the morning, 4 in the afternoon. If they're on higher doses, it can be split 3 times a day. So not only does that help with the analgesic effect, but also means that maybe any PRN pain relief, will maximise that. So I think the other thing is if you people are really struggling with pain relief, liaising with pain relief team and looking at other options for pain relief. And, the pain relief team are really good at giving advice on what to recommend.
Because the whole problem with buprenorphine is it is a partial agonist, isn't it? And it just, if you're on a really, really big dose, it's going to block opiates, even high-dose opiates. And actually, sometimes you might need to organise a transfer over to methadone or something like that. So, and that's probably, you just need the specialists involved at that point. It's too difficult to discuss otherwise. And then I guess that also goes for the Buvidal, doesn't it? Because if you've got somebody on a high dose of Buvidal, you can't really add in an opiate agonist into the situation. It's not going to make it very helpful at all.
And it's not reversible, because it lasts for up to a month, so it can be difficult to manage these patients.
So that is definitely, if you've got somebody on Buvidal who's got, some massive pain need, they're going to... that's not going to manage. It's not going to be managed with paracetamol or anti-inflammatories. You're going to need to get the pain team involved, aren't you?
Definitely.
Yeah. So hopefully we get people nice and stable, and you use the guidelines, people read them through, and all that sort of thing. I guess the other really important bit is what happens when the patients are ready for discharge? What are your top tips on getting them discharged?
I think the earlier we can do a discharge summary and get that to VIA, the better. They would say they would prefer 1 o'clock or before. So the sooner that we can do that, the better. It really helps them, because usually in the community the prescription's stopped, and they've got to do their liaison with the pharmacist to recommence that when that's from, and to ensure that's safe. And VIA want confirmation that they've received the prescribed treatment in hospital when they last had it and what the discharge summary is. So the sooner we can get that to them, the better. I do all that liaison, but obviously it's reliant on getting that discharge summary done as soon as possible. I don't tend to recommend people are given methadone or buprenorphine as a TTO, unless they're on it's explicitly discussed with VIA. And usually then we'd only do it for patients who are on once a week consumption, and they're not supervised, just because we want to minimise that risk of either the medication being diverted or them overdosing it as a result of something that we've given them.
And I guess so that it just makes it very difficult, doesn't it, I suppose, for a weekend, because you're not going to get a prescription. What would you do? Would you advise anything then for the weekend?
So I usually, if I think somebody's going to be prescribed on a Saturday or Sunday, what we want them to do is have the dose on the Saturday on the ward, and if they have to go home on a Sunday, if we can't keep them in, which would be the better option, if they have to go home, sending them home with maybe the one Sunday's dose, and the next available working day VIA will pick up that prescribing. But if we can keep them in, because the other thing is, if somebody's fresh out of hospital, they need more support. They might have been in for a while, so we want services around them to support them with that discharge planning. So sometimes weekend isn't always, for some of our patients, not always the best time to discharge them.
I mean, we do sometimes get patients who come from out of area, don't we? And I think maybe some of the I'm not sure if they've had anybody from oncology, but certainly the vascular surgery, which they come from different parts of the country, don't they? So what do you do then with them?
So with those patients, I've had it this week. I contacted the Gwent Drug and Alcohol Service, and they have a very similar setup to us in terms of they have an organisation who do the prescribing. It's not through the GP. They put the community pharmacy prescription on hold. I confirmed the dose, and then when they were discharged, I did exactly the same. So I think if somebody's out of area, letting me know as soon as possible so I can find out who the drug services is, contact them, make sure I get their details so that I can let them know.
Yeah, that's really helpful, isn't it? Because then it means that all the doctors here and the nurses here can sort of help, they pass that sort of work over to you,
I'll do all that liaison, which sometimes, the services are really busy. Anybody who's rang VIA can know that, they're really busy. So I'm more than happy to do all that liaison, on for the ward's behalf. So thinking about other scenarios, so I think a big one, we've talked a lot about overdoses. What about managing an opiate overdose?
Yeah, so I think it's just important to remember that people with heroin problems often do have underlying mental health problems. There's a lot of coexisting anxiety, depressions, etc. And, sometimes it might be deliberate. And so don't forget, I suppose, to contact the mental health liaison team. So, they're available 24/7 and they're on extension 5490. Then I suppose the other bit about opiates, just really, not quite hot off the press, but sort of quite important, latest news is we suspect that the opiate supply is going to change quite dramatically, because of geopolitical issues in Afghanistan, really. So people are going to, I think probably the Taliban are going to restrict the opiates production, and that about 90% comes from Afghanistan. In the past, that's meant that the opiates have just become weaker and more expensive, which actually has then led to less people using them. But actually what's been happening more recently is people have been adding in really potent opiates into the situation, like fentanyl or other substances. And then there's there's substances now, the nitazines that are out there. And then we had a spate, didn't we? I think last autumn of a few cases where they were suspected in Gloucestershire,
Yeah.
and there have been some in the southwest where people have taken nitazines, and that's led to overdose and actually sometimes death. So there's quite a lot of advice there about making sure patients have got information about safe using as safely as possible,
Yeah.
not using on their own, testing smaller amounts if they're not sure where it's come from, not using in more public places or with friends and that sort of thing. So those are the issues really. So the other bit about the nitazines is that actually I think we've got some evidence that they might have been added to other drugs like ketamine actually. So
Right.
that's another concerning thing,
Yeah.
particularly for the younger people who have been using.
I think one of the main things in terms of opiate overdoses and using naloxone is knowing that naloxone has a very short half-life compared to other substances.
Yeah, absolutely.
So, it wears off a lot quicker. So, it's about monitoring that patient for, a period of time afterwards, because it could be that initially the sedation levels rise, but then fall again very quickly afterwards.
Absolutely, yeah.
And I think the other thing is there are lots of specialist teams out there, such as the mental health team. We've got the homeless specialist nurse, domestic abuse nurse, and I think when somebody's in our hospital, it's a good opportunity to kind of get other people involved to assess them, to get some support in place.
Yeah.
And emergency naloxone can be given from ED.
Yes.
So that they can get that to take home with them.
Yeah, because there's a guideline, and there's actually quite a nice, I think, training video on the internet that Dr. Noble sorted out as well, which is really good. Yeah, and actually also VIA do give some of the users naloxone as well. So actually, if they come in and they've used their naloxone, actually be really good to be able to give them their replacement for when they go home, wouldn't it? Yeah.
So what about young people services in the county?
So that's currently run by the youth support team. They were prospects training. I think it's now going to the council actually, and there's a few drug workers that cover the county. And I actually have a little bit of input and do some supporting with them. And they've also got a dual diagnosis nurse who's available. And there are some really quite straightforward referrals and stuff on the internet, referral forms on the internet.
Yeah, that's one of my roles, is I liaise with the dual diagnosis nurse for CAMHS.
Yeah.
And I let her know of any young people who come into the hospital who've presented maybe as a result of substance misuse. And she will liaise with the young people's substance misuse team and with CAMHS to just make professionals aware, because it could be a part of a wider picture of safeguarding that we need to look at.
Yeah, I mean, it's just really important. I think, often they're not using opiates, but we've had the odd 17-year-old referred to us. Often their use is alcohol, cannabis, ketamine. And I think some young people just don't know where to go to get some help. So actually, I think if you've got anybody who's just used or maybe accidentally overdosed or something, just really important to try and refer. And they're a very good service. They go out and see people, see them at their own homes or in their localities and do some really good work with them. What other drugs are you coming across in your role then,
so other than obviously, like we've said about cannabis and alcohol, the next biggest I would say is both cocaine and crack cocaine and ketamine. Either used those individually or polysubstance misuse. So using ketamine and crack cocaine either together or separately. This adds a level of complication because there's not always prescribed treatment we can offer. So it's more about the psychological support. But I do use the Neptune guidelines, which are available on the internet for if anybody wants to do some more reading, just about what these drugs are and how they work on the body, but also about, if we do need to give treatment, what can be.
I think those Neptune guidelines cover like all party drugs and
all recreational
drugs and party drugs and that sort of thing, club drugs too. And what about? I suppose we do. Yes, I suppose if you're using things like stimulants, cocaine, amphetamines, you could get psychosis, I suppose, like an acute psychosis.
So we've had a case since I've been in the hospital of somebody who got referred to dermatology. I don't know how much a referral to a specialism costs, but I can't imagine it's cheap. And she got referred because of bed bugs, and she said that she had a skin condition and it was because of a result of bed bugs. And it turns out that these bed bugs were as a result of drug-induced psychosis, seeing things that aren't there. You know, a lot of these patients will complain of itching to the skin, picking the skin, and feeling like they've got bugs crawling on them. You know, referrals to dermatology for skin conditions when actually it's as a result of either thinking or seeing bugs or bed bugs as a result of crack use.
Yes,
you know, it's really costly mistake to make when it could, a good assessment, you know, could have eliminated that.
And I guess if you've got somebody who's psychotic because they're using crack or amphetamines, sometimes they do need treatment actually. And I suppose sometimes we can be, I think in mental health services, be a bit quick to sort of dismiss it all as substance misuse. So I suppose that's the other bit, is just thinking, has it just tipped somebody over into a psychosis, and there was an underlying psychosis there as well. So just really important to just not ignore that, really.
I think it's really important to, you know, to think about the DART team that we've spoke about. They're really good at offering that psychosocial intervention and looking at treatment and psychological treatment where maybe medication can't be offered as a treatment for things like ketamine and cocaine.
Yeah, absolutely.
So I know that diazepam, benzodiazepines are indicated in a lot of overdoses. Are they commonly being misused?
Yeah, so I think we know that quite a lot of the patients going for substance misuse treatments, and indeed lots of other people, are buying benzodiazepines. Whereas I think possibly people just bought it from other people who had their scripts, or locally, it's now getting, people are ordering it on the internet.
I had a patient who was 70 and she was buying benzodiazepines illicitly over the internet. So it's really easy to come by.
So yes, even old folk can use the internet. But no, that's right. But it and the problem, I guess, is that people they're ordering some stuff that, I don't know, we don't know about in the UK, stuff that's not actually prescribed in the UK, and some of it's incredibly potent. You know, really very strong, like 10 or 20 times as strong as diazepam, for example. So actually, it's really awful, and then can cause like quite nasty withdrawals, really. I suppose we haven't got any guidelines in the hospital, but you know, we found some helpful ones, didn't we, in Bristol? And I think
we're going to work on those.
But I think they're very sensible, because they're basically saying, you know, actually, if you've got somebody who's saying how much they're using, if it's just a sort of very, very high dose, probably 30 milligrams of diazepam would do it, really, even if it was a very big dose. So that's going to stop all the worrying symptoms like, I don't know, fits or, you know, very acute anxiety symptoms. It might not give exactly the same result that the patient's been having before, but it should sort of deal with any withdrawal symptoms. And actually, if you do need somebody who needs a bit more, then that needs, well, you probably, and also medic review, doesn't it, to go in and do that. And just really important not to just take it all on face value and prescribe 70 milligrams. It probably is really
just having that inquiry in mind.
Don't prescribe like for like. Tammy, do you want to say something about alcohol and cocaine? Because that's quite an interesting combination, isn't it?
Yeah, so it's what we know is it's the only combination of drugs that actually create a third substance. So alcohol and cocaine is the only combination. It creates something called cocoethylene, which is more toxic to the body. It's more toxic to the liver. The body has to work harder to process it. So without being stereotypical, you know, lads who go out on a Friday night with their mates and then play football on a Saturday morning maybe, or a bit of exercise and get chest pain. You know, that could be as a result of the alcohol and cocaine, the cocoethylene together. Because it's more toxic to the body, which a lot of people don't realise.
So I suppose it might be presenting in cardiology then, and maybe
cardiology or you know, or A&E department. You know, in an otherwise fit and healthy you know, person who you wouldn't expect to see this in.
Because I suppose we haven't talked about how much how much these drugs are used. But it's again a bit like alcohol, isn't it? You don't want to just, I don't know, assume somebody doesn't use.
Yeah.
Because they look nice or they don't look like that.
I think I've found in the hospital there's no such thing as what looks like a stereotypical user, from the lady who was misusing benzodiazepines, who was, in her 70s.
Yes.
And she was buying them over the internet. We can't judge everybody just by how they look. It's sometimes hidden.
Yeah, it's really just important, isn't it, to ask people and communicate really well.
Yeah. So the next section is we're going to look at some frequently asked questions. So the first one is, what if patients are demanding more opiates?
What you mean? So I think if we think we've got somebody we're working with and they're just demanding more and more opiates on top of their prescription, and we're I mean, I guess you just need to think a little bit more about why that is, because it might be that someone hasn't really been listening to them and they've not really checked the dose properly, and actually the patient's still getting some withdrawal symptoms and they haven't done the COWS score. So I guess that's a bit, isn't it? Just getting the withdrawal symptoms looked at. I mean, if people are in pain, then you need to have, I suppose, a real think about what is the pain, can it be managed, what can you do about it? Is it sort of explained pain or medically unexplained pain, which might, again, I suppose, lead to another thought? And how have people done through the pain ladder if they've been trying to use like weak opiates, which might make things worse? And I guess the other bit is just thinking about trying to find out a bit more about what they've been doing, because I suppose sometimes the danger is if they don't feel their pain's been adequately controlled, they're going off and using.
Yeah, they'll manage it themselves.
Which might mean that their withdrawal symptoms aren't that bad, but they are actually still using and their opiate need is still there. I mean, the other bit, I don't know whether we still have it, but it used to be a real thing where actually patients are often missing their dose. They're not actually getting the doses and they're just trying to manage it themselves and not necessarily entirely sure what that's about. I suppose the other thing is sometimes people get frustrated, don't they, if the drug round's delayed or something like that. And then equally, I guess nurses get frustrated because the patients are harassing them for drugs, so that the whole thing can be quite complicated, but just try and get understand that. I guess the other bit is sometimes people just are in a lot of pain from mental health issues, but also I think if they're very worried about where they're going to be living or that sort of thing, isn't it? It can just really make things very much worse, can't it? And I suppose if I was a junior doctor in the trust and I was really worried about this person, thinking what is going on here, and I'd done my best, I think I'd be calling you along to just see what else you could do to help to sort of unpick it all, really.
Sometimes a good assessment and talking to the person, getting to the bottom of it and having that time to do that can help. So.
What would you do if somebody was threatening to leave hospital, maybe prematurely, Tammy?
So I think the first thing I'd do is assess, why did they want to leave? Can it be remedied? So is it because are they worried about their pain's not being managed properly, their withdrawals not being managed properly, or is it because of another issue that we maybe need to look at? We discuss why we not need them to stay. So is that to complete treatment, complete investigations, things like that? A good assessment of underlying mental health problems, social issues that maybe need addressing, that can alleviate some of the anxiety. I think a good capacity assessment is really important. I know it's vital in the safeguarding team. Do they have the capacity to make the decision to go home? Are they medically fit? Or are we just waiting on one thing? So are they medically fit to go home? Is there a good discharge plan available for what they need to do for the medication? Do they know what they're doing? And I think then the last thing is, who do you need to liaise with to make sure it's a safe discharge? So even if they do leave mid-treatment, liaising with myself so that I can liaise with community teams and set something up, will help, even if they do feel that they have to self-discharge. What do we do if somebody's using polysubstance misuse and we're not sure how to kind of work out what's happening in terms of withdrawals, maybe?
I mean, it's difficult sometimes, isn't it? I guess, you're back to really assessing, really talking to the patient, being, as you said, non-judgmental, you're trying to help them, coming with that attitude, really. And then, trying as much collateral history. I mean, VIA will give you information about what they think patients are doing, how stable they think people are, what there might be might be struggling with. And in an ideal scenario, I guess you could do urine testing as well. That'll give you some straightforward testing, but that's not available really very much at the moment in the hospital. But maybe, who knows in the future.
I think for a useful guideline, we'll put some contact numbers up on the screen so that people can have the details for myself, mental health liaison, via, so they'll be up on screen now. Thank you.
Great. And I suppose the weekend is just follow the guidelines and contact mental health liaison, pain out of pain on call, and making sure they refer to you on Monday morning, I guess, Tammy, isn't it? Yeah.
And it doesn't have to be anything complicated, just a name and an MRN. You know, and I'll do the rest.
Yeah.
I think is the, you know.
Yeah. So we've talked a bit about how to really manage substances in the hospital. We haven't gone into a great deal of detail, I guess, about all the different substances that are available in the country and the county and that sort of thing. But we thought that was like the most important thing.
Yeah.
I suppose just thinking about the nurses and the doctors in the hospital, just some general principles really about what they can do to make the situation best. I mean, I suppose I was thinking it's just really important to listen to what people have got to say. I think there's a danger, I think, and certainly when I worked in substance misuse in the community, a lot of the patients would come out of hospital and their view was that nobody had spoken to them, and no one had talked to them, and no one had explained to them what was going on. And actually, we can understand why it might be difficult to maybe have that patience to sit down, but actually just doing that can sometimes really help. Really tell people what they're doing. The other thing is, I think sometimes patients who've got substance misuse problems can come across as if they know everything, and they can be a bit dismissive if you say, "Oh, I'm going to prescribe paracetamol," but actually they don't really know as much about medicines as they maybe think they do, and certainly as much as hopefully the nurses and doctors do, and actually can be amazingly great to have some pain relief. I mean, sometimes non-steroidals can be much, much more effective than they can for opiates, can't they? And than opiates can be, rather. And so it's just really important that you really explain that to the patients and talk to them about what they're doing. And actually, if you are reducing the dose, increasing the dose because of interactions or whatever, just really important to talk that through so patients really understand it. So I think those would be my sort of top tips. Have you got some other things?
I think the key for me would be, early referral would be vital. And I think good communication with the patient. If you're reducing a dose, explain why, so that they know it can be reviewed. I think reducing a dose and just leaving it sets people feeling anxious. I think the main thing, and I can't stress it enough, follow the guidelines. Please just follow the guidelines. You can't go wrong. I think it will lead you in the way that you need to go in terms of both prescribing decisions and assessments. And I think, asking for help from myself, mental health liaison, pain team, and getting those early referrals.
The other thing I was thinking about, we haven't talked about it, but it used to be a big thing for everyone to have contracts, and I always struggled a bit with those because I think often the doctors didn't want the contracts because I think they were worried that the patients weren't fit enough to go. And then I think fairly understandably the nurses were with the patients all the time and they wanted something very clear guidelines, and then you got into I don't suppose conflicts with people.
I think that we've got to approach it in different ways. I think the main first role should always be support. So, what's the behaviour that they're doing that we're finding unacceptable? Is it violence and aggression? Is it that they're leaving the ward? Explaining if it's, for example, somebody leaving the ward, explaining to them why we need them back in a certain time. Starting out by setting time limits for them to be off ward, explaining, it's because you need your antibiotics, your medication, we don't want you to miss, give them the power to understand why it's important.
Rather than just having, you've got to do this, and this, and if you don't, you're discharged. I agree.
If supporting them doesn't work, you can then do something like, a behaviour contract. But I think being very clear as to what you expect the outcome to be at the end of that. And I think if anybody's any concerns, they need to date X any incidents if they are concerned about a patient's behaviour.
Absolutely, and if there are, obviously there's violence and aggression, that's a different matter, but for most patients it is, isn't it, about really being good and communicating with them. Super, thank you very much.
Thank you.
That was really good.